Hello, my name is Adriana Hurley, and I'm going to present information about the epidemiology and control of HIV/AIDS in Nigeria.
Okay, so I'm going to give you a little background about the country. Nigeria's population is projected to grow from 186 million people to 392 million by 2050. Nigeria will become the fourth most populous country in the world. Nigeria is also composed of more than 250 ethnic groups, and even though their official language is English, they also speak different languages like Hausa, Igbo, Yoruba, Fulani, and over 500 additional indigenous languages. The first case of AIDS in Nigeria was reported in Lagos in 1986. Sadly, the reported case was a 13-year-old sex worker from West Africa. HIV prevalence increased from 1.8% in 1991, peaking at 5.8% in 2001, and progressively declining to 3.1% in 2014, according to the Antenatal Clinic survey reports. In 2010, the overall prevalence of HIV/AIDS was 4.1% in Nigeria, although rates vary across the 6 geopolitical zones in the country, with the highest prevalence in the North Central Zone at 7.5% and the lowest prevalence rate in the Northwestern Zone at 2.1%, according to the National HIV Zero Prevalence Sentinel survey in 2010. According to the National Guidelines for HIV Prevention, Treatment and Care in Nigeria from 2016, Nigeria had the second highest burden of HIV globally, with 3.4 million people living with HIV in 2014. Nigeria has the second largest HIV epidemic in the world. It is estimated that around 2/3 of new HIV infections in West and Central Africa in 2017 occurred in Nigeria. Unprotected heterosexual sex accounts for 80% of new HIV infections. Approximately 150,000 people died from AIDS-related illnesses in this country in 2017. These are some of the social inequalities that Nigerians face every day. I found them really scary, and I was a little disturbed when I was reading all these articles. For example, men who have sex with men MSM are the only group in Nigeria where HIV prevalence is still rising. In 2017, prevalence in this group stood at 23%. In 2014, the Nigerian government increased the punishment for homosexuality to 14 years in jail, and anybody or anyone assisting these couples may face up to 10 years in prison. So imagine this situation, and you can see that these people are not going to trust the system. They are not going to receive any help. They are not going to have any screening tests done. So it is very sad to see this situation still happening in the 21st century. It's really sad. Also, I found pretty disturbing that in Nigeria it is estimated that 58% of the people living with HIV are women, because women have to face a lot of inequalities. They don't have the same job opportunities. They believe that men are above women. They have the situation of child brides. So you are going to see a 13-year-old girl marrying a 50-year-old man, and this man has several wives, and they all have HIV. It is very sad, very scary to see this. Also, it was estimated that 14.4% of sex workers were living with HIV, which is less than women who actually are married and have a family. And HIV prevalence among people who inject drugs in Nigeria was only 3.4%. So we see quite a difference there compared to other countries. Methods of surveillance used. Currently, one of the methods of surveillance used in Nigeria is the 2018 Nigeria HIV/AIDS Indicator and Impact Survey. This is a cross-sectional survey that assesses the prevalence of HIV health indicators. The 2018 NICE characterizes HIV incidence, prevalence, viral load suppression, CD4 T-cell distribution, and risk behaviors in a household-based national representative sample of the population of Nigeria. And will describe uptake of key HIV prevention, care, and treatment services. Another surveillance system that has provided an effective reporting is UNAIDS, and the Sentinel surveillance system, and the Nigeria National Agency for the Control of AIDS. Burden of HIV/AIDS. We also read in the article provided in class that Nigeria accounted for 37,000 of the world's 160,000 new cases of babies born with HIV in 2016. And also this is some of the 2017 data. 3.1 million people living with HIV, 2.8% adult HIV prevalence ages 15 to 49, 210,000 new HIV infections, and 150,000 AIDS-related deaths, 34% adults on antiretroviral treatment, 26% children on antiretroviral treatment as well. So it is a big burden. Economic burden. Although drugs for HIV/AIDS are free for patients at designated health facilities and art centers in Nigeria, evidence suggests that the expenditures on HIV/AIDS care and treatment can be catastrophic to patients and their households due to costs of other components of care. Patients pay for non-art drugs for opportunistic infections, non-routine tests, medical consultations, transportation, feeding, and hospital stays. The cost of these often have impoverishing effects on some households and hinder them from getting the necessary care, especially in settings like Nigeria, where payment of healthcare remains predominantly through out-of-pocket. So even though there is coverage for art medications, there is no coverage for other type of medications, and people who are usually on art medications, they are going to need different things, and they don't have this unexpected costs, especially if they have to come out of pocket. So it's not enough to have coverage for art medications. More policies or more research has to be done so they can see how also they can help these people with other unexpected costs. This chart represents the new HIV infections by age and sex in 2017. We have 3 pie charts here. The first one is representing children and adults. Children is from 0 to 14 and adults 15 and above. We have infections in children 36,000 and adults 170,000. The 2 other charts represent adolescents, female and male. As we can see, females are more affected, a lot more than men. So in adolescent women, it's 28,000. In males, 19,000. In young people, which is young females from 15 to 24, or young males from 15 to 24, we have 45,000 infections in women and 38,000 in men. According to the World Fact Book, their 2018 age structure estimate was composed of 0 to 14 years, 42.45%, 15 to 24, 19.81%, 25 to 54, 30.44%, and you can see a huge drop from 54 to 64 years, 4.04%, and 65 years and over, 3.26%. You can see that not a lot of people make it to old age. So Nigeria has also the normal predominant risk factors. About 91% of the global 3.2 billion of people living with HIV in 2012 lived in sub-Saharan Africa. Female sex workers have an HIV prevalence of 14.4%, as I stated before, MSM 23%, people who inject drugs 3.4%. Nigeria has the second largest HIV epidemic in the world, with 3.1 million people living with HIV in 2017. But due to the country's large population, it equates to a low prevalence compared to some East and Southern African countries, 2.8% in adults. And I would add a predominant risk factor in this country is to be female. 60% of the HIV infections are among women. Current data still shows women are at higher risk of infection than men. Financial disparities and intimate partner violence in relationships often hinder a woman's ability to negotiate condom use and protect herself from HIV. Gender inequality in education and restricted social autonomy among women is directly linked to lower access to sexual health services, including HIV testing and treatment. So this is data from 2015, prevention of mother-to-child transmission progress against global plan targets in selected priority countries. So their global plan in 2015 target was to have 90% of the pregnant women with HIV receiving ART, and the other target was 90% of reduction in new HIV infections among children. So this is a comparison with other countries. If you notice Nigeria, which is the very last item, we see that only 36% of pregnant women with HIV were receiving ART, and 21% of reduction in new HIV infections among children. So you can see that 2015 didn't meet its target in Nigeria. And this chart is from 2017. This is the percentage of pregnant HIV positive women in priority countries receiving antiretroviral treatment to prevent mother-to-child transmission. Nigeria, again, is the last item, is the purple container. And we can see that even though, it's less than 50%, so it is low, but hopefully they are making an improvement in this population. So this is a topic of controversy, breastfeeding. In the United States, the CDC and the American Academy of Pediatrics recommend that HIV-infected mothers completely avoid breastfeeding their infants regardless of ART and maternal viral load. But on the other hand, the World Health Organization states that mothers living with HIV in Nigeria should breastfeed for at least 12 months and may continue breastfeeding for up to 24 months or beyond, while being fully supported for ART adherence. Mothers living with HIV should exclusively breastfeed their infants for the first 6 months of life, introduce appropriate complementary foods thereafter, and continue breastfeeding. Very different and very controversial. So breastfeeding brings a lot of challenges. For example, if my mom chooses to breastfeed, and she is HIV positive, the risk of transmitting HIV through breastfeeding is increased if the mother has a breast infection like mastitis or cracked and bleeding nipples or a breast abscess. How about if she needs to go back to work? She might need to find a strategy to continue to breastfeed exclusively when there is no breastfeeding station or support in the workplace. Maybe she won't have a freezer where to store the milk. How is she going to pump? Maybe she doesn't even have a breast pump or enough water to wash her hands properly before expressing. Maybe the mom become very ill due to any opportunistic infection, and the mom is unable to breastfeed. So it's very easy to say, oh, just give formula to the child. But remember that commercial formula does not contain antibodies, which remember they are the ones that protect the infant from infection. And these babies are more prone to common infections. Maybe also remember you need to dilute the formula in water, and it has to be clean water. The bottles have to be properly washed. So these babies actually are more prone to die from diarrhea or pneumonia or malnutrition because formula is expensive and they start diluting the formula. So these moms need a lot of support. I think that breastfeeding is a great idea, and I think that more research needs to be done so we can provide more support to the moms who want to breastfeed their children. Barriers. Many people living with HIV in Nigeria are unaware of their status. Nigeria continues to fall short of providing the recommended number of HIV testing and counseling sites. Low levels of access to antiretroviral treatment remains an issue for people living with HIV, meaning that there are still many AIDS-related deaths in Nigeria. Punitive laws against homosexuality mean that men who have sex with men face difficulties accessing HIV services. Nigeria also has the fourth largest tuberculosis epidemic in the world, with HIV and TB co-infection now becoming an increasing concern for people living with HIV. In conclusion, gender inequality must be addressed to reduce the HIV spread among women. Criminalizing laws against LGBT community have made this community more vulnerable to HIV. More research needs to be done to make breastfeeding safer. Despite subsidization of art services, it remains inequitable for the population due to indirect cost of treatment. More research needs to be done to find a cure for HIV/AIDS. This concludes my presentation on epidemiology and control of HIV/AIDS in Nigeria. Thank you.